Hi, my name is Chris Sutton, and I'm going to be doing my kidney project presentation. So, what I wanted to do it on is dehydration and how that affects the kidneys. So, we'll just go ahead and start with Miss Mitchell. So, for the case study, we have a 78-year-old female who was found lethargic during a summer heat wave. She went for a long walk during the mid part of the day and came into the ED later due to fatigue, low appetite, dizziness, and nausea. She does have a history of hypertension, recent recent diuretic increase, and poor oral intake. Her vital signs showed a blood pressure of 88 over 54, heart rate of 112. Labs that were drawn, BUN over creatinine ratio were 26, which is high, and an elevated level of sodium of 150, so 155. So she is hypernatremic, um, as well as concentrated urine, elevated serum osmolality. Diagnosis pre-renal acute kidney injury due to high dehydration. So um, So for pathogenesis of pre-renal AKI, this was triggered by hypovolemia, um, and this is what uh, this decreased renal perfusion. This is how this AKI resulted. Kidneys are structurally intact, but the glomerular glomerular filtration rate has dropped. Also, there's a risk of progression to ischemic acute tubular necrosis, or ATN. So for the sequence of events, we have a decreased circulating volume, which also decreased renal blood flow, and that also decreased glomerular uh, filtration rate. So the tubules remain functional early on, but filtration is impaired. Physiological mechanisms. So for the GF, we'll just call glomerular filtration rate, GFR, so I don't keep messing that up. Depends on renal blood flow, glomerular capillary hydrostatic pressure, and dehydration. Decreased plasma volume decreases cardiac output, which results in a decrease in renal perfusion. So compensation via the RAS is usually compensation usually happens via the RAS being activated. So the angiotensin 2 constricts efferent arterioles, and this temporarily um, preserves the GFR. Prolonged hypoperfusion will worsen filtration and result in AKI. Epidemiology, most common causes of AKI in hospitalized patients. Um, so here are the high risk groups. We have the elderly. They have a blunted thirst response. Infants, they have a high fluid turnover. Surgical patients, fluid shifts, diuretic use, or febrile illness. And here are some of the clinical manifestations. So for systemic signs, you'll see orthostatic hypotension, tachycardia, dry mucous membranes, poor skin turgor. For renal findings, decreased urine output, concentrated urine, increased BUN over creatinine ratio, as well as a decreased GFR. So here's some management strategies. Um, Fluid replacement, first of all, oral or IV, whatever they can handle. D5W to reduce ECF osmolarity, and we want to monitor their urinary output as well as their electrolyte levels. We want to hold nephrotoxins such as NSAIDs and ACE inhibitors. Um, so So in this case, I know sometimes people get confused between hypovolemia and dehydration, but in this case, we show dehydration, especially in vulnerable patients like elderly with comorbidities, which can trigger pre-renal AKI. Early recognition and supportive care are key to preventing progression to more serious renal injury. And to go over, oh, I think I included my treatment strategy. Oh, I'm sorry. I guess yes, here's the treatment strategy that I already mentioned. Um, I'm just seeing a different view um, with how I'm recording this. So here's some of my questions. We have a 75-year-old patient who's admitted with confusion and weakness. Laboratory findings reveal a serum sodium level of 152. Patient's history indicates inadequate oral fluid intake over several days. Based on this clinical presentation and the provided information, which of the following best describes the patient's primary fluid balance? So here are our options: isotonic fluid overload, hypovolemia with hyponatremia, pure water depletion, hypovolemia with hypernatremia, and hypovolemia with normal natremia. So the correct answer is pure water depletion, dehydration. Our number two, a key physiological consequence of dehydration that directly contributes to the development of prerenal acute kidney injury is A, increased hydrostatic pressure within the peritubular capillaries. B, activation of the parasympathetic nervous system leading to renal vasodilation. C, a decrease in plasma volume leading to reduced cardiac output and subsequent decreased renal perfusion pressure. D, enhanced reabsorption of potassium in the distal tubules, causing hyperkalemia. E, direct structural damage to the renal tubules by concentrated urine. And the correct answer is C, a decrease in plasma volume, leading to reduced cardiac output and subsequent. And that is my presentation. Here are my references. Thank you.